Oh, I'm sorry. The microphone was not working. So I have to start again. Hello, everybody. And some of you have requested for me to talk about thyroid disease. So I changed my topic today. So I'm going to talk to you about the management of thyroid diseases in 2020. Thyroid, as you know, is a small organ which is located in the anterior neck in the midline. It weighs about 20 grams, and right lobe generally slightly bigger than left lobe. And the, the height is usually 5.5 centimeter, and the width is about 1.5 centimeter. Isthmus is connecting right and left thyroid lobes. It becomes thinner when we are growing old. But when the thyroid become over-functioning, then this thin portion of isthmus become hypertrophic, so that you may see even we call pyramidal lobe, which is in the midline arising from the isthmus. As you see here, we have a large lymph node around the thyroid and in the neck. And generally, you have to go by the levels. Level 1A is submental, right here. Level 1B is around the mandibular angle. Level 2A is around the carotid space. Okay, from hyoid down to cricoid cartilage, that's a level 2 level. And if you have a lymph node around the medial, lateral, sternocleidomastoid muscle, that's a 2B. Below cricoid cartilage, that's a level 3. And then down here, paraclavicular level 4. Level 5 is around here, lower neck in the midline. Level 6 is a superior mediastinum. So whenever you see some lymph node, you have to describe and then make a precise location according to the levels. That's what our oncologist expects to know that. Because of so many lymph nodes, CT, MR, ultrasound may not be easily differentiate from parathyroid adenoma because they are all soft tissue. Okay, just like any other hormonal system, you have a feedback system of thyroid system. Hypothalamus, okay, release thyrotropin hormone and stimulating pituitary to activate the thyroid gland to make a thyroid hormone. T3 is much more potent hormone than T4, although the amount is less. And thyroid hormone, as you know, plays an important role in metabolic process, growth and development, and also catecholamine effect. So there is always a feedback system. If you have too much thyroid hormone, it triggers the pituitary and hypothalamus to release less hormone. So again, what you say? You have a question? No? All right. now here, thyroid function is again important role in growth development, and it stimulates heart and also synthesis of proteins, carbohydrate, and it degrades cholesterol, triglyceride, and enhance beta-adrenergic receptors to secrete more catecholamine, and also increase the vitamin requirement. So it's vitally important in our body system. Again, thyroid in the blood, iodide from salt, various foods, transport by sodium iodide importer. And then inside the follicle of thyroid, then this thyroglobulin secreted, and this iodide bind to the thyroglobulin and to makes T3 and then T4 and release. So after release, and I have another here, the plasma iodide comes and transport, and then bind to the thyroglobulin, and the continuous iodination makes a mono di, and then mix together, make a T3, T4. Okay. So again, thyroid-stimulating hormone stimulate the thyroid follicle, and then iodide combined with thyroglobulin and makes a iodine, and the thyroglobulin here, and then 2 iodine makes a diiodine, 1 iodine mono, and combination tri, and 2 double di makes a T4. So T4 is about, T3 is a 10%, but this T3 has a short 2.5 days. T4 is about a week, and it's much more potent. And this will make our metabolic activity. So in our routine clinics, you measured total T4, now free T4, total T3, and free T3. These are the range in general laboratory. TSH, so TSH, we routinely measure TSH. So total T4 is a thyroglobulin binding hormone. So there's a binding influence by hormones, medication. So if a certain lady takes a birth control pill, and then you may have erroneously high T4 because thyroglobulin binding capacity is enlarged. But nowadays, so therefore, radioactive iodine thyroid uptake was essential in old days. That's a direct measurement of thyroid function. But now with the free T4 and free T3, you don't have to do that. This does not affect by thyroglobulin. And together with TSH, so diagnosis of thyrotoxicosis, hyperthyroidism, or hypothyroidism is very easy. And as you see here, in euthyroid, you have radioactive iodine uptake in this level, okay? But in thyrotoxic conditions, the uptake is low, but T4 free total is very high. And TSH is low, uptake is also low. But in hypothyroid, the other way around, TSH is very high, and the uptake is also rising, but T4, free total T4 is down here. So thyroglobulin is a glycoprotein produced by thyroid follicular cells with stimulation from pituitary TSH. The thyroglobulin is a precursor of thyroid hormone T3, T4. It is about 25 nanogram percent. And 70% of normal subjects has this normal range, but pregnant lady or infant baby has relatively more thyroglobulin. The thyroglobulin is increase in TSH suppressed therapy and or recombinant human TSH stimulation, thyroglobulin is high. Now, iodine 131 therapy also makes a thyroglobulin high, and Graves' disease certainly high, and medication like carbimazole, methimazole, operation, these all TSH is high. Obviously, the follicular or papillary cancer also showed the increased level of thyroglobulin, and that's just a problem. After surgery, you don't expect to see any thyroglobulin, but if this is rising, then you have to suspect a recurrence. Anaplastic, undifferentiated cancers do not show increased level of thyroglobulin. Goiter is just enlargement of thyroid, functioning thyroid, that shows the thyroglobulin high. Certain leukemic blast cell in the bone marrow showed increased level of thyroglobulin in 10 to 25%. Normally, when we suppress the thyroid with T3, the thyroglobulin should be less than 0.1 nanogram percent. With iodine 131 therapy, it should be less than 2 micrograms. So we use the thyroglobulin as a marker for possible recurrent thyroid cancer. Increase the thyroglobulin, but decrease TSH, that's what you have a suspect for recurrent thyroid cancer. And this approach shows also 12% false positive and 30% false negative. So nothing is perfect. About 25 to 30% differentiated thyroid cancer has this kind of false positive negative. So in hypothyroidism, that's overfunctioning thyroid, you have to consider trauma, certain medication to stimulate thyroid, or certain hereditary congenital, most commonly inflammation. Any disease in thyroid is somewhat related to inflammation. So chronic thyroiditis, that's a lymphocytic that's called Hashimoto thyroiditis, is the most common cause of everything, thyroid disease, hyperplasia, or even cancer eventually. Okay, certainly hormonal influence, right, by miscarriage, pregnancy, and some irregular sex, menopause, those all also affect the thyroid in overfunction. Certainly, trauma to pituitary also, because of a feedback system, cause sometimes hypothyroidism. As I mentioned, inflammation or infection. The bacterial infection is called acute thyroiditis. Acute thyroiditis is very severe, painful, and febrile, etc. And viral thyroiditis is a subacute. It's slow, subacute, and that leads to chronic thyroiditis. So sometimes a certain nerve shocks, recurrent large nerve comes into this mid portion of thyroid, as I mentioned when I talk about parathyroid. A certain nerve shock apparently through recurrent laryngeal nerve stimulating thyroid and makes a thyrotoxicosis. So you can see some bulging eyes, okay, the exophthalmos. That's a very special condition of Graves' disease, hypothyroidism. Lymphocytes accumulate in the back of this eye. And so why, nobody knows. And this eye problem is more frequent in Asian ladies. American ladies generally have a very deep located eyeball, and they don't have much exophthalmos problem. So sometimes we radiate because lymphocyte is very radio sensitive. And this exophthalmos is still quite a mystery. And the anxiety, the symptom of thyrotoxicosis is sort of overutilizing thyroid hormone. So patient become very nervousness and tremor, and obviously thyroid gland is palpable, enlarged, about usually 3 times larger than normal size. So it's about 40 to 60 grams in general. And because of wasting energy, they feel all tired. And the skin becomes very thick and red, and heartbeat is pumping fast, irregular sometimes. So you have to try to calm down the patient by sedation and certain even depressing medication. So again, we usually check free T3, T4, and TSH. Free T3 and 4 are elevated, and TSH is suppressed. And then direct measurement thyroid function by radioactive iodine. And obviously scan is helpful to see any cold nodule. Cold means less activity compared with the surrounding activity. Hot nodule means a nodule with greater activity compared with the surrounding background activity. Warm nodule is a nodule palpable, but no increase or decrease activity you can visualize. So that's all relative. So why we need this one? Well, greater than 1 centimeter nodule is usually palpable by experienced endocrinologist or internist. Okay, and when the nodule is palpable If the function of the nodule is less than surrounding normal tissue, then if that nodule is a 1, the chance of cancer is about 20–25%. If we have ultrasound scan nowadays in same patient, you'll see many nodules. In old days, ultrasound resolution was similar to the resolution of nuclear medicine. Nuclear medicine resolution still around 1 centimeter. So less than 1 centimeter nodule may not show up on a nuclear medicine scan. But nowadays, ultrasound, CT, MR resolution is about 1 millimeter. Anything greater than 1 millimeter nodule will be shown on the images. So anyone over 40 years of age, you expect to see nodule because a nodule is an aging process. When you're getting old, tissue become degenerated. Micro nodule become macro nodule. Macro nodule become adenoma. Adenoma becomes adenocarcinoma eventually. So a nuclear scan is helpful to guide a certain measurement. Ultrasound is a very sensitive, but too sensitive to show many sort of aging-related nodules. So ultrasound research doesn't have such a correlation of cancer incidence and nodularity because too many nodules nowadays. Now, if you have all this elevated T3, T4, and decrease the TSH level, uptake high, that's a diagnosis of hypothyroidism. In that, diffuse type is called Graves' disease, which is usually in young ladies. Generally speaking, thyroid disease is about 10 times more common than male. Okay, 10 times. It's probably related to hormone influence. Now, if there are, well, in 2% of diffuse goiter, Graves' disease have a nodule, usually 1 or 2. But if you have multiple nodules, more than probably 1 or 2, it's called plumose disease. Plumose disease usually occur in the 50, 60 elderly ladies. In contrast to young ladies in Graves' disease. But there are certain single, one predominant nodular goiter means enlargement that is autonomous, hard nodule, maybe suppressing surrounding normal tissue. There has been some report of mutation, certain gene mutation, like every other disease. And other conditions, thyrotoxicosis, factitia, certain medication, and viral subacute thyroiditis. This chronic thyroiditis can cause a hypothyroid and euthyroid or hypothyroid, a variable up and down, But during the active acute thyroid hormone is released from follicle, so patient become toxic. In subacute, the viral is a slowly up and down, So it's a variable. This Basedow syndrome is similar to Graves' disease. Struma ovary, ovarian teratoma, has ectopic thyroid tissue and makes a sort of a uptake of iodine 131 or iodine 123. So that's basically ovarian teratoma. It's called struma ovary. Now, metastasis, the functioning differentiated thyroid cancer can cause thyrotoxicosis. And so excessive iodine intake obviously cause. So again, in enlarged thyroid, you have a diffuse type, multinodular type, uninodular goiter. Graves' disease cause is a iodine deficiency, goitrogen-induced goiter, and certain unusual lymphoma infiltrated amyloidosis. So that's a diffuse infiltrated type. Toxic plumose disease, toxic multinodular goiter, and a certain colored nodule, iodine deficiency, some goitrogen-induced goiter, infiltrated, metastasis. Most common metastasis to the thyroid is a breast cancer. By and large, that's not most common. But for cancer, melanoma is most common for cancer. And so rarely lung cancer and lymphoma. And the unilateral goiter, as I said, single hot nodule. That's autonomous hot nodule, usually related to thyroiditis. Okay, certain, that's a adenoma. Now this, you can see, here is a bulging eyes, bilateral. Sometimes one side more than others. Yeah. So if there is clinical signs, symptoms of thyrotoxicosis, you check thyroid levels and TSH level. And then we usually suppress the thyroid function first with short-acting anti-thyroid medication, propylthyroid uracil, and rarely you may end up having a thyroid storm that require emergency admission. Patient become almost dying with a rapid heartbeat and usually difficult breathing, etc. Because thyroid hormone released rapidly and then it makes a real high toxic. So first you have to slow down heart. So usually beta blocker, propranolol, and then you have to sedate, usually Valium, Librium, sedated. And then you have to block entry of the iodide into the thyroid follicle. So this kind of trapping and amplification, you block both by this medication. And then certainly you have to, after patient become stabilized, then you have study uptake, see how much. So high, diffuse on the scan, that's Graves' disease. And then if uptake is not that high, usually thyroiditis. So, and then you monitor thyroid function. Now, in the treatment thyrotoxicosis, you have only radioactive and iodine 31 therapy is still treatment of choice of all patients, including children. Anti-thyroid medication has agranulocytosis as a side effect. And also after a couple of years, the drug developed resistance. Surgery, complication about 20-25%. parathyroid is right attached to the thyroid posterior wall. So when they remove calcemia, hypocalcemia, calcium control is a problem. Then another one is, as I said, recurrent laryngeal nerve comes into the middle portion. If they cut, the patient develops permanent hoarseness, and that's a major disaster. So nowadays, using parathyroid imaging, those complications are rare nowadays. But the unexperienced surgeon, because endocrine surgeon usually knows well about these things, but general surgeon who occasionally make a thyroidectomy can make this kind of unexpected complication. Now, for iodine 131 therapy, diffuse thyrotoxicosis, okay, that we usually give around the 10 millicuri iodine 131, 8 to 10 millicuri fixed dose. And for plumose disease, toxic nodule, which is a lot more radio resistant, so we usually give 25 to 29 millicuri iodine 131 as a one dose. Certainly metastatic functioning thyroid cancer is well responding to iodine 131 internal radiation. But other types of thyrotoxicosis is not indicated for iodine 131 therapy. As you see here, cervical thyroiditis, thyrotoxicosis factitia, and thyroid hormone resistant, and certain pituitary tumor, other sort of trophoblastic tumor, stroma, that kind of things make a secondary hypothyroidism, and Hashimoto disease, Basedow phenomena, that's iodine-induced hypothyroidism. Those are not sort of indicated for iodine 131 therapy. So again, reviewing in the management of hypothyroidism, you have to consider medication, radioactive iodine surgery, but radioactive iodine therapy is the choice now, except for pregnancy, pregnant lady, breastfeeding that. Medication, as I mentioned, create side effect agranulocytosis, and the permanent sort of a medication makes resistant to the certain common drug, propofol, uracil, methimazole, that kind of things. But initially, to prevent thyroid storm, or if you have to give a high dose radioactive, you have to always think about thyroid storm, so you slow down with medication and then give iodine 131 therapy. Surgery is considered now a certain as cosmetic reason. Young, like 20, 30, even benign thyroid nodule, I recommend the surgery. The benign nodule may make a transformation to cancer. So surgery at young age good with careful this parathyroid and recurrent laryngeal nerve. Okay. And using optimal dose radioactive iodine therapy, half of the patient become permanent euthyroid. The other half develop slowly hypothyroidism. So endocrinologists nowadays once make a patient quickly hypothyroid so that they can take a thyroid pill just like a vitamin pill. every day without coming to endocrinologist often. Okay. And the surgery, obviously, if they remove her, it become hypothyroid immediately. But the real problem with surgery is calcium, as I mentioned. Okay. So the fixed dose is 8 to 10 mercury, but ideal dose, you measure the gram. So as I said, usually 20 gram is normal, but Graves' disease is about 40 to 60 gram, and uptake is around 15 to up to 20% normal, but Graves usually 40 to 60%. So 40 to 60 percent. This gram is a 40 to 60 gram divided 40 to 60%. This one. So you're giving 40 gram, and this of 100 microgram 40 and times 100. That makes a fixed dose about 10 millicurie, 10, 50. So we are now trying to give a less radioactive iodine to minimize side effect, that is cyanoadenitis, that makes a dry mouth forever. So during the therapy, we have to encourage the patient to drink lots of water, to eat some sour, either juice or fruits, to stimulate parotid or some secretory cells for the saliva. So we have to continuously work on this side effect to minimize. Okay, subclinical hypothyroidism is not unusual, subclinical. And so using routine T3, T4, TSH, TSH, usually if there's a very low, very high, you have to repeat in 6 weeks. And if TSH is greater than 10 international unit, then you have to check some antibody for chronic thyroiditis, and then certainly T3, T4 you check. If TSH is less than 10, you check antibody, thyroglobulin, etc. And then you make some wait and see if this is low. If hypothyroidism, you give some thyroid medication. Now, as I said earlier, scan makes a functional status of nodule called HOT1. Hot nodule practically does not suggest any cancer. Only 10 cases in the literature have been reported associated with cancer, hot nodule. But as I said, single cord nodule has a chance of cancer in 20-25%. Multiple cord nodule has about less than 4% chance of cancer. Now, ectopic thyroid functional tissue can be easily detected with the thyroid scan, such as a lingual thyroid or struma ovary, they say ovarian teratoma, with the functional thyroid hormone. And certainly, we occasionally see some widening of superior mediastinum. Then you have to always include the mediastinal substernal goiter thyroid, lymphoma, and thymoma. Those are 3 differential diagnosis. And then we have whole body system to see any metastasis. The most common thyroid cancer is a papillary. Papillary usually spread out to regional lymph node and eventually lungs. But the folliculars usually goes to lungs and bones, hematogenous. But they often combine together. So you make a thyroid uptake, and then Graves' disease, and then uptake is useful to measure the dosage of iodine 131, and then certain some questionable thyroid disease, the uptake is direct measurement of the function. The radioisotope we are using for thyroid scan and therapy, there's a sodium, technetium 99M, sodium pertechnetate, and iodine 123 sodium iodide, iodine 131 sodium iodide. As you know, technetium iodine 99M and iodine 123 has a very good physical properties, optimal energy for gamma camera, and optimal sort of physical half-life, 6 hours versus 13 hours. And iodine 131 has a beta and gamma. The gamma is a 364 kb. Beta is a 600 kb. And half day is 8 days. Therefore, one microcurie, iodine 131, deliver about 1 to 1.5 rads. Rad is 100 ergs per gram. Technetium, 1 microcurie, delivers 0.001 rads. Iodine 123 makes 1 microcurie makes 0.001, so 10 times more than technetium by this slightly higher energy, slightly longer physical half-life. So nowadays, iodine 131 is used only for therapy because of too much radiation. And so for scan, either technetium 99M, sodium pertechnetate, or iodine 123 sodium iodide. As you know, iodine 123 is produced by cyclotron. Technetium 99M produced by generator. So it's much cheaper. So here, this tongue base has the lump. This could be enlarged tonsils, but here on pertechnetate scan, you can see very intensely increased activity. That's ectopic. Thyroid is supposed to be lower neck anterior here. But this is a ectopic sublingual thyroid. If they remove this one, then patient will need the thyroid hormone forever. Okay, so they have to nowadays they remove or partially to make a breathe or a swallow better, and implant this tissue in some place to make a thyroid hormone. And then you can see iodine 123 scan on the left side, very sort of activity smoothly. Okay, no sort of a background activity. Although there's activity, you just don't see it. Here, because of expensive, we are usually using 0.1 or 0.2 millicurie. Iodine 131, we can still use a 1 millicurie. If you give more, photon numbers are more, so sensitivity is higher. But you notice the images show very sort of non-uniform, or maybe the dot is too big, high energy, and background here. These are markers. So for the diagnosis in United States, we use iodine 123 sodium iodide, although it's much more expensive. But I like to point out advantage of technetium-99 and sodium pertechnetate. Somehow, many physicians don't understand that this comparative finding clearly. They assume that iodine 123, iodine, sodium iodide is a functional agent. Technetium is not functional agent. Therefore, they order always iodine 123 scan. However, as I mentioned, the cost is almost 100 times more with this one. And the radiation is 10 times more here. The imaging time is also technetium. After we inject, particularly we are injecting 10 to 20 millicurie, 10 to 20 mil, so photon numbers are a lot more. We are giving a 0.1 or 0.2 millicurie. So photon numbers are much less. But here we inject and have a scan in half an hour. Here, you have to wait 4-6 hours, and then sometimes 24 hours, because iodine 123 or 131 sodium iodide has to be trapped by thyroid follicles and organified. So it's a slow process. Technetium, on the other hand, is only trapped and washed out, so that you have to have imaging quickly. So imaging quality is far better with technetium. And also, because of much higher dose, you see the background activity only with technetium. So if you measure the width of thyroid and width of the neck, if the thyroid width is greater than half of the neck width, then that's a thyroid enlargement. For iodine scan, you cannot measure thyroid because there's no background or activity. And also, compared to background activity or submandibular or salivary gland activity, we can measure at least thyroid trapping function. So trapping is a part of thyroid function. And the only problem in the literature is that there is a potential discordant images between this, only if these are exceptional. What kind of condition? Organification defect. In children, we call goitrous cretinism. Goiter means, as I said, enlargement of thyroid. Cretinism is hypothyroidism. That's usually related to organification defect. So if we have a iodine scan, you're not gonna see anything, nothing, because there's no sort of organification. So it's a trapping but release. But technetium trapping, there is a compensatory increase trapping in those conditions. So technetium scan shows diffusely increased active, just like a Graves' disease. On the other hand, iodine scan show nothing in goitrous cretinism. That's due to organification defect. This is one of example. Nodule here, and this is technetium scan because of we see salivary mandibular gland and the background activity. And because of almost hard nodule here, and the thyroid is right here. Neck margin is about here. But this nodule has a trapping. But when we repeat with iodine 1, 2, 3, since this iodine 1, 2, 3 has a little higher energy, and then you can follow this technetium scan with this iodine 1, 2, 3. But the other way, if you do iodine 1, 2, 3 first, you cannot do technetium scan because it's a longer half-life, the activity remaining. But anyway, this is 1 day apart. So here's a very hard nodule. You don't see that here. So this nodule, this looks like an autonomous hard nodule, suppressing the rest of the gland. However, here iodine scan suggest this nodule has organification defect. And the palpable nodule, it is 5 to 12% are malignant. Okay, and the females are a lot more common in any nodular lesion, 6 times, and even cystic nodule can be malignant, although it's a very small percent, just like a renal cystic nodules. Okay, and the even a solitary nodule by ultrasound, that's a multinodule. Only 1% multinodular, so less than 4% is a malignant. So that's a well-known statistics in nuclear medicine literature. But ultrasound literature does not have this kind of correlation because ultrasound has been improved in resolution. So more and more nodules are seen. So in the differential diagnosis of thyroid nodule on the nuclear medicine scan, you have a benign, malignant, autonomous hard nodule, and warm nodule. Warm is activity similar to surrounding normal tissue. That's usually adenoma. So if you palpate some nodule or ultrasound show nodule, but nuclear medicine doesn't show anything, that's usually non-toxic adenoma, hyperplastic. Hyperplastic tissue become adenoma. This macronodular hyperplasia become adenoma. The benign cold nodule as a cyst, usually cyst, but some adenoma, some thyroiditis is a nodule, some abscess certainly. Parathyroid adenoma embedded inside the thyroid tissue. Malignant, papillary follicular most common. Hotel cell is a aberrant type of follicular cell. Now, anaplastic medullary are not functional. Function means trap and organify iodine to make a thyroid hormone. They certainly lymphoma, metastatic tumors are not functioning. So here, this is again salivary parotid mandibular body margin. Here is a width and the neck margin here. So thyroid gland is slightly enlarged and shows a nodule here with less uptake, less activity. So this is a cold nodule. Now, where is this nodule? It could be inside the thyroid tissue. It could be front or behind the inferior part of left thyroid. So without oblique, without speck, you cannot tell. So nowadays, at MD Anderson, we always use SPECT CT for any tumor imaging to make a precise location. And also, we can characterize this nodule based on anatomical imaging like a CT, MR, ultrasound. If there's a calcification, that's a usually benign adenoma. You cannot talk about calcification, necrosis, etc. on this nuclear medicine study. Okay, a hypoechoic, no calcification. Calcification makes a post-acoustic shadow. You don't see that. This is a common follicular thyroid cancer. So in ultrasound literature, they try to characterize benign versus malignant. Most commonly just shape, so just like any other imaging, well-defined, usually benign, but irregular, poorly defined, speculated, that's it. And a certain microcalcification in thyroid or breast, that's usually malignant. But actually big calcification, that's usually benign, benign. And that's about it. Other things is not clear cut in differentiating. So although sometimes those usually show hypoechoic, but some benign make hypoechoic in 10 to 20. And some, that's a rare, but it's happening. So they show various this nodular shape things, but ultrasound evaluation is always dependent on individual operator who is using transducer. So depending on experience and the position of the transducer, you'll see various imaging findings. But ultrasound is cheaper, easily available, so that's why they always start with ultrasound in any palpable thyroid nodule. And so here margin is a little bit irregular. There's some echoes here and some echoes inside here. Some nodules can be burned out by high frequency ultrasound, just like a liver. It has to be less than smaller size. But this kind of treatment always create some problem. By heating, they can melt down a major portion of tumor, but tumors always in surrounding, more active in the surrounding margin. So we once they use a heat, then the blood vessels around it become dilated, and the tumor cells around escape very fast. So they knock down tumor, but they help to metastasize fast. Fine needle aspiration is still a popular procedure. Cytologists, experienced cytologists make a helpful diagnosis. But again, there's a very small amount of tissue cytology experience require things. So it's still used routinely, but you cannot just totally rely on by just fine needle aspiration. High suspicion, low suspicion, and that kind of diagnosis based on certain ultrasound features and the cytologies. Now, these are multinodular. If multinodular, this is enlargement goiter. If the hormone uptake is high, that's plumose disease. Single hard nodule suppressing, so autonomous, as I said earlier, this mostly adenoma. And then so we can give 20, usually 25 millicurie to knock down this function, or surgery if it's a young patient. Now, FDG often show incidental hotspot here, left thyroid, bad. So the thyroid here. So this usually suggests medullary thyroid, non-functioning. So well-differentiated thyroid cancer takes out FDG slightly, but anaplastic or medullary takes a lot more. So that's FDG uptake, as I mentioned many times, has a lot of influential factors: glucose transporter 1, hexokinase 2, and the pH inside the tumor cells. pH, lower pH, acidic makes more uptake, and certain enzyme and phosphate enzymes, and also certain genes affect thyroid uptake. So this incidental loma was found in about 2-3% on PET scan, mostly functioning papillary thyroid, but in other literature, mostly medullary thyroid. And then, so the finding the expression necessary, still don't know clearly. Standard uptake value cutoff, we don't know. Standard uptake value has also some variables, imaging time, amount, etc., so that it's not totally reliable. Just a visual inspection compared with the surrounding, mild, moderate, marked uptake is good enough. For the same patient and follow-up purpose, SUV, this quantitative number is still valuable. So in this incidental loma, and the breast cancer still mostly common, that's a metastasis, that's a uptake. But other cancers uptake things. So in thyroid cancer, with the ultrasound, it was rising rapidly about 10 years ago, but with experience, it slowed down, but still quite common in female, and we now see very young patient as well. But it's still good cancer. Only 6% died of cancer. Recently, they live longer. So now with this genetic studies, we found a certain RAS gene, BRAF gene in all the cancers, and then red gene also in MEN related to medullary thyroid cancer. So this BRAF gene is related to fully differentiated thyroid cancer or anaplasty. So this makes angiogenesis. So spreading to other organs responsible with this one. So we now have a drug to block BRAF gene function. So that's an important thing. And certainly de-differentiate from well-differentiated to the de-differentiated. There's obviously a lot of genetic effect, And there's P27, even tumor suppressor gene, P53, plays a role. And beta-catenin is also mentioned in the literature. So if we find the red gene in the medullary thyroid cancer related to MEN, then we have a tyrosine kinase inhibitor, Gleevec, works very well. But anaplastic, de-differentiate, if we find the BRAF gene, then sorafenib Vemurafenib, this kind of things have been used. Otherwise, just the standard chemotherapy, bleomycin, doxorubicin, cisplatinum, and sometimes Taxol, sometimes works. So in the gene, usual gene assay, particularly RAS and P32, helpful for new kind of chemotherapy. Papillary, as I mentioned, goes to the lymph node. Follicular goes to the lung, liver, bone, and the for medullary, neuroendocrine tumor, agent, octreotide, and even old days technician DMSA, dimethylcaptosuccinic acid, was used to demonstrate medullary cancer. For metastasis, FDG PET scan is useful, particularly in patients with a negative iodine scan, but elevated thyroglobulin. That means the cancer becomes de-differentiated. It's a poorly differentiated. And then FDG usually show the lesion. Obviously, ultrasound shows small nodules in recurrent tumor or metastasis. But small nodule, ultrasound cannot tell whether that's functioning or non-functioning. Okay, so again, in the histology, we have most common papillary, and then second is follicular. And these are all functioning thyroid. It's a mixed together, mixed. Anaplasty is non-functioning. It's a small cell. Sometimes this is a small cell, as I mentioned, the other small cell type is all neuroendocrine. And medullary and lymphoma, and so even sarcomas occur, sometimes rarely things. And the again, papillary is well-differentiated low grade in the beginning, but this become slowly differentiated and then anaplastic. So if there is some way we can predict that kind of biological transformation, that will be great to manage those patients before too late. And once they metastasize, that's usually go to the lymph node and the lungs, so multicentric. Cancers in general are not localized disease, it's a systemic disease. And certainly large tumor, elderly patient show poor prognosis. Folliculars is the next common, usually hematogenous metastasis to the lungs, liver, bones, and it's pathologically similar to adenoma. Cortical cell tumor is a variant. And the metastasis to the bone is certainly also long bone is a common problem. This medullary anaplasty is related to this multi-endocrine system, as I mentioned last time, and particularly medullary is calcitonin is elevated. Okay, and undifferentiated anaplasty usually worst, poor prognosis, elderly patient. So this not functioning. So we use radiotherapy, external beam radiotherapy, and then chemotherapy. Okay, now, okay, we need some about 10-15 minute sort of break. Okay, then I will continue on this thyroid diseases. Okay, so now my time. Okay, here in Korea, so it's 10 after 1 p.m. So I will start maybe 10 minutes later. So why don't you go to restroom or have some drink and come back. Before I start my talk, I want to remind you to make any question, comment, criticism to improve our lectures in the future. So please do not hesitate to raise anything you like to have, or we have to change our certain lecture style or content, whatever. So give us your feedback. Thank you very much. Okay.
Thank you, everyone. Before starting, I want to inform again about Professor Edmund Kim's comment about there is a link of questionnaire, so you can freely please participate in that questionnaires. And if you have any kind of comments or question for this lecture, you can freely write down at the chat, and then we can have some time to discuss your questions after the lecture. Thank you very much.
All right, the multiple endocrine sort of neoplasia as a type 1, 2A, 2B. This been always on the exam or many things. MEN1 is a PPP, pituitary parathyroid pancreas. These are usually P27 gene mutation, mTOR gene mutation, and histone certain transferase has also a mutation. Now, MEN2 has a medullary thyroid cancer. MEN2A8 has a parathyroid. MEN2B has a neuroma in addition to adrenal tumors. Now, neurofibromatosis, one has some association with the tuberous sclerosis. That's often related to mTOR mutation. This is also seen in other tumor, astrocytoma, renal angiolipoma, islet cell, pancreatic cancer. And tyrosine kinase inhibitors such as sorafenib, pazopanib, XL184 have been used in many cancers. But this kind of sort of target therapy has a certain very limited sort of success. Just like any other target, there are too many targets produced by cancers. That's the reason. And also, if we inhibit a certain target, the other target try to compensate. That makes always a problem. So it works in limited patient and also temporarily, but it's still helpful with the relatively less side effect compared to standard chemotherapy. mTOR mutation related to protein angiogenesis has also inhibitors. That's called everolimus, and also certain VEGF inhibition or somatostatin suppression together works better with this mTOR. And in thyroid or stomach cancer, BRAF gene mutation is not that common, but once we find we have a drug, but it works, the resistance has been found with the loss of a P10 gene, which is a tumor suppressor gene. So continuing some imaging through my ovary, which is a ovarian teratoma with ectopic thyroid tissue, functioning tissue. So when we give iodine 131 or iodine 123 sodium iodide, just like a thyroid, it trapped thyroid tissue. So ovarian teratoma with ectopic thyroid tissue showed. And we can possibly treat with high dose. But usually in this kind of things, the surgery is usually because there are small other satellite, we don't see that clearly. So surgery, if surgery is not feasible, then high dose iodine 131 therapy, we should be helpful. And MIBG has been used. Certainly, this is a methyl guanine. As long as there is a chromatin granule in the tumor, that's no epinephrine producing. So any tumor with that chromatin granule will show up here. So mesothelioma cancer has a small cell, and this is a neuroendocrine sort of behavior. So using popular gallium-68 dotatate, that's the best now with for any neuroendocrine tumor for diagnosis. You can see mediastinal subcarinal lymph node metastasis show. And certainly when the thyroid cancer become dedifferentiated, anaplasty, FTG uptake is so intense. I just said submental, that's a 1A, and surrounding mandibular angle 1B. Here, okay, a jugular vein and carotid here. And so around here is a 2A. Around. And sternocleidomastoid muscle here, so it's a medial, lateral, that's a 2B. Here we have, so this is more likely 1B surrounding mandibular angle, but here looking whole down. So here this is more likely. Here there's a 2B because the sternocleidomastoid here, but around here, so more likely 1B down to 2A and B down probably 3, that kind of things. So all, and this is 6 superior mediastinum here. So TNM classification, thyroid cancer is by size less than 2 centimeter, oops. And that's a stage 1, and 2 to 4, greater than 4 is T3, stage 3, and the lymph node distant metastasis. So this kind of TNM classification is not that really important in thyroid cancer. And the here diagram also show by TNM classification, and the certainly papillaries and the extrathyroidal or invasive certainly expect to have a poor survival. And lymph node, the positive, negative certainly makes It's anaplastic worst. And the recurrence, overall recurrent thyroid cancer, if there's no recurrence, so thyroid cancer still is a good cancer in overall, yeah. And the after operation, thyroid is like a fragile tofu. So during operation, they almost all surgeons spill invisible tumor cells. So we always have a sort of a follow-up whole body scan, and after we stimulate, and then there's always some residual thyroid tissue that should be ablated. Because if there's any remnant thyroid tissue, there is a higher risk of recurrence. So we have a whole body scan, and we check a serum thyroglobulin and images after we stimulate by utilizing recombinant human TSH or natural rebound wait certain period. So, but patient become so sick without any hormone. That's so we now more and more endocrinologists use recombinant TSH. That's intramuscular injection twice before we have a scan. If a scan show positive, then we usually ablate by using high dose iodine 131. So there have been lots of changes of guideline by American Thyroid Association or a British Thyroid Association and the oncology groups. So basically they divide into low risk group, intermediate risk group, and high risk group. Oh, there's a lot of noise. If there's a question, you can link and write down. If there's a microscopic metastatic lymph node less than sort of 2 millimeter size, and that's a very low risk. Localized, that's low risk. If there's a less than 3 centimeter lymph node and the BRAF gene mutation positive, that's the intermediate risk. High risk is a high thyroglobulin after surgery and lymph node greater than 3 centimeters. That's high risk. And so in this recommendation, papillary thyroid in the low risk, okay, and the low risk group, there's a follicular variant papillary thyroid cancer, and the no metastasis and no invasion of regional tissue things. That's a low risk. And the if we have a scan, no uptake outside the thyroid, just the thyroid ablation. And intermediate, metastatic, and then so vascular invasion, and that's a intermediate. So we used to recommend a total thyroidectomy, but nowadays, if there is a young age with a small cancer, low risk group, is a lobectomy is allowed. Lobectomy. And then they recommend a moderate neck dissection for follicular variant Hurtle cell cancer or medullary thyroid cancer. And the T4 should be very low, and TSH is very low. And if there's a bony metastasis, certain diphosphonate or zoledronic acid or external, if there's a single metastasis, external beam therapy to relieve pain and to also knock down tumor cells. Now, iodine scan, we have to wait 486 weeks post-op. After certain low iodine diet, and then we give a human recombinant TSH 0.9 milligram intramuscular injection to raise TSH up to about 30. And then we usually give 5 milligram iodine 131. So for ablation, we used to give 100, but if there's a low risk group, lower dose, 30 millicurie, to minimize sialoadenitis. For recurrent, usually 100, 150. For long or bone metastasis, around 200 millicurie. And it's and then oncologists often use this chemotherapy for dedifferentiate, anaplasty, that kind of thing. So thyrogen is a thyrotropin sort of recombinant human TSH intramuscular injection twice to make a TSH at least more than 30 international units to stimulate any residual thyroid cancer or tissue. And then anything overdose always consider a thyroid storm. So if there's a clinical symptom suggesting thing, you have to slow down heart, you have to relax patient by sedatives. And now this thyrogen interact with the very many drugs, so you should be very careful. Particularly common metformin, that's diabetic drug, and atorvastatin for cholesterol drug, Lasix for renal clearance, Hydracept for reflux, gastric reflux, xanthine acid, gastritis. Now, if there's a BRAF gene in the thyroid cancer, it is supposed to be less effect with iodine 131 therapy. So we use this kind of dabrafenib, selumetinib to redifferentiate it, and that would be good for iodine 131 therapy. So I'll mention again later, redifferentiation. If there's a red gene and often familial type inherited thyroid cancer and a drug to block red gene, dabrafenib, serpicatinib, PAPA, that's a sort of a nucleotide receptor. We use alpha-2 If there's a JAK gene, ruxolitinib, it's all new drugs here. All the thyroid kinase or vascular endothelial growth factor suppression with the new drugs. So these are all new therapy have been helpful in certain dedifferentiate, polydifferentiate, anaplasty. Oops. So again, total thyroidectomy followed by scan and sometimes uptake to measure dose, but standard dose is if the positive, usually ablation 100 milliculi, and low risk young patient, divide into 2, 3 smaller doses, and then later scan to see, and then follow up, scan and thyroglobulin assay. Greater than 1 centimeter in 2009 was recommended for total thyroid, but now with the recent new guideline, only greater than 4 centimeter is total thyroid. Less than 4, just a lobectomy is still recommended, lobectomy. So in 2009, thyroidectomy, okay, was for small, less than 1 centimeter, low risk. Still, there's 2015 small lesion, and the thyroidectomy is recommended. So no change much in this small, low risk. In medullary thyroid cancer, if calcitonin is increasing, FDG scan, it's a localized disease. Sometimes DOPA, this kind of sort of malignant tumor like a brain glioblastoma. Many tumors have certainly a dopamine substance, and that show well in localized disease. And then for localized disease, surgery is okay, but if there's a distant metastasis things, then targeted therapy or chemotherapy recommended. Okay, for follow-up of thyroid functioning cancer, and the Iodine 131 therapy was given to ablate any residual thyroid tissue. But that's only for papillary follicular, not the anaplastic medullary. So the image again for follow-up, and the complication, well, certain false positive, you may think, in the thorax with iodine 131. Certainly swallowed saliva in the esophagus, and some certain thymus show up by sodium iodide symporter, same principle. And certain pericardial effusion, mediastinal pool, and showed, and non-lactating breasts have shown. And these are all mechanisms is sodium iodide symporter, transporting things, gastric, certain inflammatory, maybe increased vascularity after post-op, certain skin contamination, certainly. So here we see something here, whole body, well located. If you use this spexity down here in the left thyroid, and a little bit middle, there could be in the tongue base, or down in the lymph nodes, and the up here, this is a maxillary sinus nasal area. So this ethmoidal sinus here, you don't know exactly where it is, but especially it's helpful to localize abnormality precisely, and then certainly characterized by CT separately and together And also the CT, it may show tiny small lesion less than 1 centimeter, which is not going to be shown on nuclear functional study. So additional certain small lesions can be picked up by CT, MR, any hybrid imaging. So here we have some focal increase activity. Where is it? By here, as I said, if this is around this mandible angle 1B, if this is something here near this carotid space, that's 2A. If down here, the sternocleidomastoid mastoid muscle here, that's a 2B. So labeling. Here we have iodine. Nothing you can point out as a focal increase activity. But on FDG, you have multiple lesions here, here. So in the neck, left supraclavicular lymph node, one down here, this right lung base posteriorly, lung. It's all metastasis from follicular cancer, which may become dedifferentiated from well differentiated. As I say, FDG shows some uptake in well differentiated, but just very slightly. When the tumor becomes dedifferentiated or poorly differentiated, the uptake is much more intense. Now, thyroid hormone withdrawn versus recombinant TSH, this recent recommendation, at least 3-4 weeks, waiting, unless you use a recombinant TSH to bring TSH at least above 30 international unit. So this in United States, one injection, IM injection, intramuscular cost $3,000, so twice $6,000. So that cost may be a problem in other places. Okay, so as usual withdrawal, the effect ends up same, but the patient convenience is totally different. Usually 1 month without thyroid hormone makes an exhausting situation to the patient. So in the United States, people like recombinant human TSH is popular. And this is just low diet and injection twice, and then whole body scan. But if they use just withdrawal and they low diet after they switch T4 thyroxine into short-acting T3, and just a couple of days and stop and low diet, and then yes. And the post-op whole body imaging may show some vague uptake in the neck, in the thyroid bed. That could be residual disease or remnant. And whatever we see, we usually give at least 30 millicurie to ablate, 30 to 100 millicurie. The diagnosed dose is usually less than 3 millicurie, iodine 123 or iodine 131. And the radioactive iodine ablation is not routine for low risk, but should be for intermediate and routine high risk. That's a recommendation. So in low risk, 30 millicurie, and then high risk, 150 millicurie. And so this is also, as I said, 30 millicurie to prevent side effect, thyroidinitis, a dry mouth forever. And then, but high risk, usually 150. So this high dose exceeding 150 milligram 131 is sort of a maximum for elderly people for treating either lung or bone metastasis. So this kind of empirical dose has been challenged. In the United States, if we give more than 30 millicurie, we have to admit the patient. Yeah. And so by dividing 29.9, 29, that they don't have to stay in the hospital. So there are many such some kind of flexibility. And the pulmonary micro metastasis by particularly follicular cancer has been treated with at least 100 millicurie, 100 or 200 millicurie. And they still recommend the same. And this is certainly sometimes it works well, sometimes it doesn't work well because so small microscopic was tiny metastasis, and but there's no other method except for targeted or chemotherapy. So it's still they recommend, but weak recommendation. Now, if there is a negative iodine scan, but thyroglobulin is rising, that's a dilemma. And so then we think about microscopic tumor, invisible tumor someplace. So we still use empirical 100 to 200 millicurie, and then followed by thyroglobulin. Thyroglobulin level often becomes less. So that means there is some invisible microscopic metastasis responding to iodine 131 therapy. So that's a weak recommendation. After we give iodine 131 high dose therapy, then we usually recommend limited sort of traveling and sleep in separate bed and avoid direct contact with the children, and we encourage to drink lots of water and void in own sort of a toilet. And so that's usually immediately after treatment, 3 days. After a week, but still flush toilet twice, and then wash hands frequently, and do not engage in kissing or sexual relationship. Do not share food or drink with others for a week. Yeah. So xerostomia, that's a major complication with iodine 131 therapy, and because of dry mouth, dental problem is also checked frequently, and sometimes obstruction of nasal lacrimal duct can happen, rare. Now, let's talk about this sodium iodide symporter. And that's symporter is a protein, with about 600 amino acid, and the transmembrane, and then some extracellular glycosylation site. And this was, first maybe targeted molecular imaging and therapy. Iodine 131 is a first theranostic agent, theranostic. And for the differential thyroid carcinoma based on the principle of sodium iodide, the symporter. That's has a certain this kind of symporter glucose transporter 1, and it is a well differentiated cancer. Less differentiated cancer has a less symporter, but you can see more glucose transporter 1. That's why FTG uptake is increasing. But here, glucose transporter is very little bitty. So in opposite side, well differentiated, poorly differentiated, FTG is only useful in poorly differentiated. But iodine 131 whole body is useful for well differentiated. And so for the FTG pad, when we have a certain primary unknown, this FNA is not clear, or some immunoglobulin increasing, but a radioiodine scan negative, and certain suspected undifferentiated cancer, then FTG PET is indicated. So here again, iodine 131 show just the physiologic secretion in salivary gland and stomach, excretion into the urinary bladder. But FTG certainly show residual or recurrent or metastasis in the right side thyroid bed. And the iodine scan show some lesions, but FTG show a lot more intense lesion in the mediastinum and the liver. So this suggesting de-differentiating or poorly differentiating from well-differentiated thyroid cancer metastasis. And the other also show this kind of old scan, but spec iodine 131 is scattering artifact that makes it difficult to detect. But the FTG show clearly in the left perihilar metastasis. And the in old days, thallium was used for cancer. Thallium is also directly, that's the sort of potassium sodium exchange in the cancer cells. But poor physical property makes imaging bad. So no one uses thallium 201 nowadays. And the sort of again, sometimes iodine scan show clearly, but PET scan doesn't show, vice versa. Here you don't see. That's all related to the functional difference of the tumor. Iodine scan show metastasis clear in the bone, rib, spine, but here PET FTG show rib lesion, but not on spine the lesion. So this lesion is de-differentiated, but this lesion is still well differentiated. Choline it was tested to detect invasive follicular thyroid cancer and adenoma that based on membrane potential difference, choline makes some amino acid metabolic process. In the literature, MR spectroscopy also shows cancer with very high choline peak, but adenoma show no choline peak. And the again, therapeutic approach is different in well-differentiated iodine 131, but when the tumor becomes D-differential or poorly, certainly chemo, target, external beam radiation, or surgery. And the response of iodine 131 therapy is related to sodium symphotor. If the symphotor immunohistochemistry stain positive, the response is much higher. Now, this sodium iodide symphotor can be enhanced by retinoid, and the certain activated receptor, some aromatic fatty acid, and certain histone deacetylase inhibitors. That's epigenetic sort of influence, and DNA methylation. These two are the epigenetic. Heat shock protein 90 also influence of this symphotor, so inhibition is helper, and transcription factors. So these are still under some research, but there are. So for example, retinoic acid makes a much bright, intense metastasis. Obviously, FTG show lots of things. So if we're trying to use iodine 131 for the therapy, we may enhance uptake with the retinoic acid. So, but tumor in general has all heterogeneity. So some, in the same patient, some like this lesion, after iodine 131 therapy shows response is much smaller. It's smaller. However, there was a lesion in the sort of either spine, I don't know. It's it show up only on FTG, so it's obviously de-differentiate or poorly differentiate after treatment. So some is better, but some is new or worse. So roughly 50% response, and then 30% refractory to iodine therapy. So it's quite a mixed response, yeah. And the 60% did not accumulate iodine 131, and but 15% refractory patient showed a significant amount of iodine 131. So in targeted therapy, we have to use gene or a lot of factors in microenvironment, tumor microenvironment, because of heterogeneous tumor biology. One factor cannot help much. You have to combine. That's the limitation of chemotherapy or targeted therapy. Heterogeneity is a hallmark of the malignant tumor. That's a very difficult to do that. And so it sounds like a nice personalized therapy, but person has too many targets and too many heterogeneity. That's a problem. So cause of death in thyroid cancer is still related to lots of local recurrence, in particularly anaplastic cancers. So continuous research on radionuclide gene therapy, sodium iodide symphoto gene delivery into tumor cell, plus iodine 131, certainly will make a better and more killing tumor cells. And so gene therapy is still in sort of research, not in clinical practice yet. And we now become interested in all this alpha emitter, actinium or rhenium 180A. It's again theranostic approach, and this kind of isotope delivers much higher radiation dose than iodine 131. Again, using certain adriamycin or gene thyroid toxidase gene and certain gene transfer or tumor suppressor gene and some sodium iodide symphoto gene will possibly make an improvement of this radionuclide gene therapy. And the whole body MRI diffusion weighted image show increased signal intensity in the metastasis. And the contrast enhanced MRI show also something. And FDG show in the liver something, but intensity is also minimal. So PET, FDG together, PET, FDG, and MRI together certainly makes a good way to evaluate any tumors in the soft tissue, but it's still expensive, it's limited to use. In the research, microRNA to diagnose a thyroid disease, but you know, for this ultrasound guide needle aspiration and this profiling microRNA, and then even machine learning makes separation of benign lesion, malignant lesion more clearly, and therefore they report very high sensitivity and specificity in the papers. So I finish up summarizing general sort of management of thyroid benign and malignant diseases, and the thyroid cancer has to be managed by the sort of endocrinologists and nuclear physicians together. As I mentioned in the other time, we are in the service department, and nuclear medicine start with radioisotope used in endocrine, particularly thyroid diseases. And so you have to make a good relationship with endocrine physician surgeons. So try to attend their conferences, or I invite them to update their approaches in nuclear medicine conference. So you have to keep continuously how you improve your service to manage the patient better and better. That's important. Many in old days, when I was in MD Anderson long time ago, I was in charge of thyroid clinic, and then we control everything. But now endocrine people control thyroid clinic, and so using all this targeted therapy, they handled more and more patient with sort of a long follow-up things. And in the earlier days, after we use radioactive iodine therapy, they live 5-10 years, and then everybody died. So that was so simple. But now, with their living at least 10 years, 20 years, or sometimes 30 years following radioactive iodine therapy, the recurrence tumor becomes more and more de-differentiated and poorly different, so that those tumors are handled by mostly endocrine or oncologists using a targeted new therapy or chemotherapy. But we still have to approach together with maybe enhanced iodine 131 uptake and treatment. That indicates several ways to make iodine uptake better with the retinoic acid and other things. So we have to keep also working on those new research for that goals. So my message again is to work together with all primary physicians. If you have any question, you can talk to me now, but you can also give me either email, or you can link certain this remote control system for any question, comment, criticism, or suggestion to improve our lectures in the future. Thank you very much. I will stop here. Is there any questions? Well, coronavirus is still very active worldwide, so I want you to keep your good health by washing your hands more frequently and by putting masks whenever you be outside or you work with others. So I will probably give you talk on infection, and I will certainly make some good comment on coronavirus, together with some other infectious diseases.
질문이 네.
Yeah. Okay, there is a question about high intensity focused ultrasound for the treatment of thyroid nodules. And well, you know what? Sometimes we injected alcohol. Alcohol also melt some certain cancer. So ultrasound, all these local therapy is certainly helpful, but in my experience, ultrasound high density technique makes basically heat, so that the periphery of the tumor always has a more active cells. So when we put the heat in the tumor bed, then there is some kind of vascular sort of dilatation, so that those patients seems to have a good response of primary tumor, but I found more sort of a quick metastasis in other places. It's not been reported, but from my personal observation, very disappointing. So this kind of local heating therapy should be indicated for very small lesions, but surgeons argue that small lesion can be easily taken out by surgery. So that's always argument. If the tumor becomes bigger, and if you melt down the primary center, then you always create the problem of escaping cancer cells in the penumbra surrounding a primary tumor. So in the liver, we limit nodule less than 3 centimeters, only in the periphery. And in the thyroid, very rarely we use this kind of injection of alcohol or ultrasound high density. If nowadays endocrine surgeons are very good to avoid the parathyroid problem or recurrent laryngeal nerve sort of problem. So we recommend the surgery more often. But in earlier days of our research or experiment, ultrasound used and show clearly some melting down the primary tumor, but always a risk of invisible cancer cells in the periphery that can be easily escaped out and metastasis to the other places. So the good indication is critical. So basically that's a small tumor. Once you see necrosis and large tumor, then there is always a problem. Okay. If there is no other question, I hope you type your comment or question, anything on the survey through the link. Then we'll try to improve our lectures and try to meet your demand. Okay, I'll see you next week. if there's no other questions. Thank you very much again.
답변.
Oh. There's some question. If differential thyroid cancer patient gets external radiation therapy, will it reduce sodium iodine expression? Yes, but we never recommend the external beam radiation for differential thyroid carcinoma. External beam radiation is only useful for anaplastic, dedifferentiated. Since differential thyroid cancer is responding well with iodine 131 therapy, there's no point to utilize external beam radiation therapy. External beam radiation therapy, that's basically heating again. Heat pass through all the tissues in the neck or thing. So, it certainly killed the DNA of the tumor cells, and also recently produced maybe some inflammatory reaction with cytokine. So remote certain individual metastasis may be also controlled by the inflammatory sort of immune response. However, as you know, all the tissues by radiation become sort of less flexible and sort of a stiffness, and that makes a very uncomfortable feeling of patient in the neck, and also covering some esophageal or laryngeal or salivary gland, the dry mouth, dry, all this, that problem is much more severe. So it's not recommended by anyone now. Only anaplastic, non-functioning type thyroid cancer require local external beam radiation therapy. But more and more oncologists use targeted or chemotherapy instead of local sort of radiation therapy. As I mentioned again and again, cancers are not local disease, it's a systemic disease. We just don't see invisible cancer cells. So particularly with aggressive tumor, you must consider systemic therapy from the beginning. Okay. I don't see any more questions. So just, yeah, if you type things, then we'll try to answer all the questions. All right, thank you again. Have a nice day and see you next week.